Got it. Okay. Uh, Let me start with a concept statement. Like the provision of electricity and water, heat and light to our homes, healthcare is a public good. And as a public good, like all those utility aspects should be regulated. I found it fascinating this weekend, by the way, that Governor Kotek, who was in Eugene, making comments about the loss of the facility there in Eugene, she made a comment and she said, healthcare is a public good. I was so glad to hear official acknowledge. That's why I start here with health.
Your signal's interrupting a bit. Maybe on our end, Keith. I don't know if there's anything you do.
Yeah, he's frozen for me, Mike.
Yeah.
Now he's back.
I'll not move and I'll go a little bit slower. It might have been I moved a little bit. Um, Healthcare is considered, a quote public good because the language is affected with the public interest. And thus, one of my positions is that as a public good, it should be regulated. And we keep dancing around it, but if we are going to have a universal healthcare system run by the state of Oregon, a lot of aspects of what will be providing will be as if it was a regulated industry. Um, some of the fundamental concept under universal healthcare is it must be equitable, meaning in terms of access to healthcare services. That's a value statement. It requires that all eligible individuals be enrolled in a plan, meaning universal coverage. A lot of the terms are being overused and overspoke, so I'm going to use them almost as if they were synonymous with one another. Access is critical to what I'm going to define as a basic healthcare system. And access, as you will see later, is how do people get into the system? And that's going to require, when this program gets up and running, a serious look at as to how people access. Recently, I had a discussion about children and how important it is to have children access healthcare as soon as possible, and also to provide children with the value of continuing to enter and use our healthcare system. So we don't have this broad gap in when children use it. And by the way, that means that children should be educated as to the value of seeing a doctor. And one of the main ways of getting education and getting kids into the medical system is through our schools. And we've lost sight of, in the olden days when I was a kid, one of the first practitioners I ever saw was a school nurse, who would always keep me advised on what it meant to have health care. One of the other things I looked at in pulling this material together is the World Health Organization, which has some really good recent publications on what is part of a basic healthcare system. And they have a good discussion on universal healthcare and, again, access to healthcare and universal coverage. And one of the recent studies looked at, what's the criticism of a universal healthcare system, and its wait times. And I just want to make a comment about, and I'm not going to go into a lot of detail about wait times, but I'll give you a quick note. Recent studies on wait times for people accessing healthcare was done by the United States, and the study used the Veterans Administration, which, by the way, is a truly socialized healthcare system. It has government-owned and operated hospitals, and all of the employees are government employees. And its wait times, by the way, have improved dramatically and are on par with the same wait times we see in Canada, the United Kingdom, and France. And then you've probably also then noticed that veterans are now, if the wait time is unreasonable, veterans can access private health care and the government pays for it. So basic health care, you want another model, the Veterans Administration provides a decent model for what would be included. Health coverage is defined as the capacity of a health system to serve the needs of the population. So I'm going to continually say that the beginning of Oregon's universal healthcare system is going to be a lot of analysis. And this is another area, are what exactly are those things that the population needs. Coverage would then also needs to look at what is the infrastructure. So we need to do an inventory of what exactly exists. What are our human resources? That's everything from our doctors to nurse practitioners to medical aides, et cetera. Health technology is going to have to be inventoried. That includes an inventory of all medicines and, of course, some financing. Universal healthcare coverage implies that there is an in-place organizational mechanism that provides coverage to the entire population. The American Medical Association has a code where it too looked at what is basic health care. And in designing it, they had 4 concepts. First, basic health care must provide preventative care, such as vaccinations, screenings, and health education. I'm going to keep underlining health education. It must also have curative care, such as diagnosis and treatment of acute and chronic illness. It needs to have rehabilitative care, such as physical therapy and occupational therapy. And last but not least is palliative care, such as pain relief and end-of-life care. And I'm going to add to that because a behavioral health component must be built into Oregon's basic health care. So in essence, basic healthcare services are usually provided by a primary healthcare provider. And there's 2 that I'll talk about at the end. That's your primary care doctor, and what I'll also lump in there are internists and what are the differences, but also what are the overlaps. Because those providers are trained to address a wide range of health needs, and also they're used to coordinating with other specialists. So any basic healthcare system has to start with, again, access, and the key providers are going to be your primary care physicians. The other thing to watch out for is healthcare services vary depending on a geographical area. And Oregon is a prime example of that. The needs in rural Oregon are not the same as those needs in urban, and urban, they're not the same as Eugene versus Salem versus Portland. And so part of our analysis is going to be, what are the overall needs, and more importantly, how do people access healthcare services in those different geographical areas with again, different populations. A value statement is all people everywhere have the right to achieve the highest attainable level of health. And this is a premise that is pushed again by the American Medical Association and also by the World Health Organization. Primary health care is a community-oriented approach to healthcare, and thus all the healthcare systems within your plan need to be integrated. And again, they must provide the most comprehensive service. I'll now jump to physicians. And by the way, at the end of this, I also give you a list of what Oregon's public employee healthcare system provides. So what my approach was to look at as many sources of what is basic healthcare to come up with a starting list. Again, physicians are regularly confronted with the effects of the lack of access, and they also are great sources of input onto how to improve access to healthcare. Basic healthcare, according to, again, the American Medical Association, has a broad approach. It has to be totally transparent. It must strive to include the needs of all the stakeholders throughout the development of whatever the process is that will be your healthcare system. It must protect the most vulnerable patients of the population. It must consider all scientific data. It must seek to improve health outcomes. Something that needs to be stressed is that whatever we set up needs to have mechanisms that provide constant feedback. And this would be feedback to whoever's governing Oregon's healthcare program, and that would be the state, because it's always going to be in a state of flux. It's always going to be changing. It won't be a static approach. There must be built-in monitors to the different types of care provided to the different geographic areas of the state. And again, the review process must provide for adjustments to those, not only for the providers, but to all the people who use the system, meaning there must be a really good feedback mechanism in providing any healthcare, most importantly, basic healthcare. Okay, coverage. One way to examine coverage is how do we access healthcare? Meaning, what are the entry points to healthcare? And that includes transportation to services. That includes home services, meaning services that are in residence or some other care facilities. Again, how do individuals find themselves in the healthcare system? That is going to be an important question that the governing board should look at. I'm just skipping over some of the other points. So what exactly is primary care? The idea behind primary care, according to World Health Organization and the AMA, is to provide neighborhood go-to medical locales for every patient. So it's a neighborhood delivery of care that is easily accessible by every member of a community, however that community is defined. The most important role is first contact, and then wellness decisions. And most of what we're seeing, the programs fall apart with after the initial visit, and this is critical with children. After that initial visit, we don't see them, and they have the built-in attitude of, well, I don't need insurance. I don't need to, I never use healthcare. I'm the healthiest person on the planet. That needs to be changed around. So what services do primary care practices offer? Preventative care is the key focus of a good primary care practice. Regular checkups, immunization, and managing chronic health conditions. That's the core or a very broad statement of primary care. The key to primary care, I can't overstress this, is access, especially for children, and education of those children, so when they become young adults, they understand the value of staying healthy. Again, schools are a key factor in providing that. I bring that up repeatedly because of the significant number of homeless in Oregon. A large component of that are children in schools. And so they're the ones that, who will be needing healthcare, and it would be the school that's going to identify those individuals. So what are some important aspects of what I'll call primary care? Notice I've moved from basic care to primary care. Some of the most important services include well visits and physicals, immunization for children and adults, treating acute illness, managing chronic illness, nutrition and weight loss, maternity and pediatric and adolescent care, basic women's health care, including pap smears and other services. And again, I want to add continually services required in behavioral health. So again, who provides that? We have physicians, are your primary care individual or providers, and they would also include certified nurse practitioners, physician assistants, DOs, and other technicians. what's the difference between primary care and internal medicine? In a lot of cases, there's overlap. I think internists and primary physicians should be together to make in designing whatever basic healthcare system we're going to have. That way, we'll make sure that we're not missing anything. And so I'm not going to go through the list of and the distinctions between internists and primary care physicians. Um, I I agree with the World Health Organization that they both are critical to providing primary care and also important to the design of whatever your basic slash primary care is. Um, Jumping to the end of this public employee health care plan, I'm just going to read a list of what they look to. Again, preventative services. So preventative services is a repeat in all of the documents and literature that I looked at. Immunization, critical. So preventative services and immunization are on top of all of the programs that have universal health care and what is called their basic care. From there, the employee healthcare program jumps into what they categorize general treatment services. And it's an interesting list. It includes acupuncture, dental, diagnostic, disease management, pain management, home care, hospice, and palliative care. Again, I found that breakout an interesting, just I found it interesting. I'm curious as to why they broke it out into a separate category, again, called general treatment services. Other services in the plan is transplant services, and they also have services that they consider additional, not primary, hip and knee replacement. And I don't know why they have pharmacy at the bottom. I think pharmacy should be included up at the top of the list. So again, that's a summary of the types of things that would be in what are called primary care slash basic care. Who are the main providers? Again, they would be your physicians and internists and their staff. And again, the question about how do we access and how do we educate and how do we design this system so it has good feedback, close monitoring, and it constantly improves itself. So that's it, folks.
Okay, thank you.
We did have we did have one question that was posted. Do you want me to go ahead and
Yeah,
read
please.
that? So
Yes.
Susan Malero had posted, she wanted to know about specifically for people with disabilities and mental health services, as well as support groups for like diabetics, depression, stress, sleep apnea, things like that. How do those types of services mesh in with all of what you're talking about, especially when it comes to access? Susan, is that kind of an accurate representation of what you're asking?
Yes.
Okay.
You know, and that's a great question, and I'm going to lump that in an area where the plan or program is going to have to reach out, and that's going to be part of collecting who are they, because they don't regularly get access or get into the system. Meaning there's a lot of those folks in the categories you just outlined that are not part of the quote basic care, primary care. So it's going to be, let me back up and say some services should be part of basic care, but how do we get them into the system is going to require a active system that reaches out and identifies them, who they are and where they live. Because a lot of them, by the way, don't have easy access. You know, think about someone who's got a serious disability or a serious behavioral issue. There's no ability to get them into the system. They can't get themselves there. And it's an important area that needs to be looked at and considered. So we're gonna have to the system has to reach out to them. Let me put it that way.
Got it. And kind of follow-up question for me just on Susan's issue and again, when talking about access, what about the person who does have some sort of disability, and they live out in rural Harney County. So that even adds another layer, right, of issue, not only finding them, getting them into the system, but also trying to find ways for them to be able to access those services. So, that's one thing I've talked about with a number of people. And you mentioned it. I mean, the healthcare needs of, there's some similarities between the healthcare needs of people in Multnomah County as opposed to rural Malheur or Harney County. However, there are so many other layers of difficulty that are associated with the rural versus urban, correct?
Yeah, and we've got a lot of resources out there, and this is a pet peeve of mine, and nothing is coordinated. Um, Mobile health clinics, I'll just use that term as a generic throw out, are going to be critical. And again, it was interesting in all the senior centers I've advised and worked with. Senior centers were a great source of who's out there. They knew who their community was. And also another one that people just seem to access, public libraries. You ask seniors, where do they go and what do they do? Public libraries and senior centers, and couple that with a very good designed mobile health clinic. In Nevada, when I worked on the system, we used the senior centers and the libraries in local communities to tell them when the mobile clinic was going to be there. And there were a lot of mobile home parks, and we did a lot of work going to those mobile home parks. But we got the word out through senior centers and public libraries. So I'm right on with you on what we got to do in that aspect.
Great, thank you.
Mike,
I should be able to, can you hear me?
Yeah.
Oh, okay. Just a year ago, I was in Cuba and they had exactly what you were describing, Keith. One doctor for every 4 or 5 blocks, available 24 hours, 7 days a week. You would go to the door, and if the doctor wasn't there, then there would be a sign telling you which neighborhood did have the doctor. The doctors knew everybody in the neighborhood would visit their homes and see what health conditions were. We probably can't do that. We can't duplicate it, but we'd like to get close.
Yeah, Mike, I gotta, I'll bring up another thing. What we found is the senior center in Nevada I ran, we linked up with Meals on Wheels. And what my paralegals would do is when the Meals on Wheels truck went out to communities, the paralegal would get out of the truck with the food deliverer and give them a card saying, do you have any legal needs? And that led into living wills, physician directives, powers of attorneys, etc. And during those discussions, we found that we identified healthcare needs. And when they got back to the office, we immediately contacted the county health official, and we said, we got a community out there that's got some needs. And again, there's the pieces are there, but no one ties them together. And that continues to frustrate me no end. And it's a huge issue here in Oregon. I mean, gigantic. No one is, I call it an A95, which is a federal program clearinghouse. There is no clearinghouse identifying all these entities providing services that should be tied into our healthcare program.
I want to ask a kind of a follow-up to Mike. Cuba, it seems to me, partly pulls off having a doctor in every neighborhood by having their medical school be free. Do you think we have to go that route in order to have enough doctors for everybody? So that we could actually have a doctor in every neighborhood. People are sometimes waiting 2 or 3 months to see their own primary care in the US. Much less to be able to walk down the block and see a doctor. What do you think that's the reason they're pulling it off, or are there other reasons?
Yeah, I think that's part of the reason. Another I worked with the medical school in Reno, and it was real difficult. And so where's the medical schools? In urban areas. But getting them to reach out to the rural areas, and 30 miles outside of Reno are two major rural areas in desperate need of healthcare, and we couldn't get them to extend their services out there. Another vehicle there's one here in Oregon, they're called medical legal partnerships. Finally, after years of arguing, the American Bar Association now allows lawyers to go into partnership with doctors and run mobile clinics. So,
Wow.
and you will, and there are terrific vehicles of providing again services because of the overlap. And we again, one of the areas that was helpful was when we were looking at again powers of attorney, healthcare directives, which led to all sorts of again identifying health needs. And then it also was part of the developing end of life palliative care issues. So,
Okay, thank you. Other questions?
We're working on the audio here. Still getting echo, right?
Yep.
I was getting a lot from Mark. I'm getting a little from you, Mike.
I think it's because you have both of the computers in the room unmuted. Mute
Oh,
one
yeah.
of them, you should be good.
I'll mute myself.
I try.
Now both are muted.
Let's see if they can.
How about now?
Yep, there you go.
Yep.
Ooh.
I have a comment, and it's about public health, how that made such a difference in, like, when we're talking about Cuba, I was inspired to think about Costa Rica during the pandemic and how well the people were reached, especially in the rural areas, because they had nurse practitioners and PAs who were assigned to a certain population, and they checked on those people routinely. And the thing that I thought was really important was at that point, the state of Costa Rica was spending $1.29 per person per year in public health, compared to the United States, which was spending 17 cents per person per year on public health. So I think we need to develop a public health infrastructure so that we can get those rural folks and get public health better funded at the baseline. So anyway, just a comment.
Yeah, I think there's a lot more room for those so-called allied health professionals in our population health model that we really need to move to, right? To really make it successful.
Bruce might have a comment.
Bruce?
He didn't have his hand up, but he would be one I'd like to hear from.
Oh, Bruce, Mike would like to hear if you've got a comment.
Okay, yeah, sure. I have many comments, but we'll just pick one. One of which was that there was actually written in SB 770 wording specifically put there to have the task force consider the usefulness of public health in a well-designed system. Public health has been, repetitively defunded over the past 2 decades. So there's pretty much our public health system in Oregon is existing on a wing and a prayer financially. But yeah, there's so much that public health could add to the whole call for universal health care. I mean, they're in the community anyway. So they would be a great resource, but it just hasn't been developed, at least not out of the 7070 task force. They didn't have time to address it.
Alex, got it?
Alex?
Yeah, well, that's funny, Mike, because I was going to ask Bruce the same thing, but I have a specific question about that, which is like local versus higher administration. I mean, public health, correct me if I'm wrong. I mean, public health is mostly like a county function, right? So how do you, what's your opinion? I mean, would that be, is it just funding? Do we just, would like a state-based universal health care, would it just be allocating funds to the county? Or, I mean, how do you see it? Just funding like county public health, or or would it be more appropriate for like a statewide public health? I'm just curious.
I wouldn't divide it. Public health should be incorporated into Oregon's universal health care. And how public health is administered and how, again, people access it would be key information to the designing of Oregon universal health care. Once you segregate it, now you start talking about separate funding, and that's a nice way of choking it off. So it should be absorbed into the system.
And that was the intent of the clause I wrote into 770.
And I
Yeah.
1000% support that.
Yeah.
Right on.
So
Yeah.
just on the subject of public health or existing public health, there are counties that the county commissioners choose to have no public health service because for various reasons, maybe because they don't believe in public health, maybe it's about the money, because standing up a public health system like we have in Benton County or Lane County or Multnomah County requires quite a bit of funding to get all the services up and running to be effective. So there are counties, there's probably six or more counties in the state that have chosen to not have public health. And in fact, one of the health officers during the pandemic was covering 3 counties out east, Malheur. So she was covering 3 counties out east, and she had personal threats from the population. They had to actually get her an escort. So that's the other thing that we face with going with a state-based healthcare system or a state-based public health system, is that there's people in Oregon that don't trust the state to do anything.
Yeah, a story when we wrote the first emergency medical service plan in the state of Nevada, I was out working in all the rural areas, and they had no ambulance services. And they were all in these, quote, unincorporated areas. So they weren't cities, they weren't towns, they were unincorporated. So in order to get them into the system to use the emergency medical service, the state paid for ambulances and put them in all fire departments, all of them. And then we use volunteer firemen and women to service them, and that's how we developed the EMS standards for EMTs. And so those rural areas, those unincorporated areas, were getting medical services through their fire department. And one funny story was we couldn't find an ambulance, but a funeral home donated one of their hearses, and we converted the hearse into an ambulance. But that's how they got into the system, to the EMS system. So where there's a will, there's a way.
That's a pretty great story. Other questions or comments?
If I lived in Crook County and I did not trust the government, what strategy would you use, Keith and Bruce, to make it seem to be in their best interest?
I'll be candid with you. We're gonna go back to the providers. A great deal of assistance is gonna be needed of the physicians, the primary care physicians, and other medical care people to break that barrier.
In Canada, if you are graduating or you are immigrating as a physician, you're likely to be assigned, say in British Columbia, to the rural areas first. We're doing something kind of halfway there that Bruce may be more familiar with, is adding incentive to work in a rural area, paying off some of their medical education debt. That's still going on a little, isn't it, Bruce?
Yeah, and another example of our problem, and I really hope there's someone on the governance board representing all the tribes, all the reservations, all of our Native Americans. They have the worst healthcare, yet they want to be part of this universal healthcare. And I hope there's someone on the board representing them, because they are going to help designing how we get out there to those folks.
They've been pretty well represented, haven't they, Bruce? At least one member of the task force was representing the indigenous tribes.
Well, what was remarkable during the pandemic was how OHA, which is where our statewide public health system is housed within OHA, did outreach to the tribes, and they accepted it gladly. So that was kind of a good test water, I guess I would say, as to the kind of outreach that could be very helpful. I mean, they were, used to smallpox killing off their populations and such, and so they wanted to do what they could to protect their populations from COVID.
Okay.
Part of the answer, Mike, to you is what Bruce just mentioned. I think that would serve as a good model on how to overcome that barrier, that stigmatism.
The task force did have listening sessions with a variety of groups, and among them was indigenous groups, and they did express a little concern about being neglected, as they have been over the last 200 years, and not trusting government. So there's a little bit of that element, I think, they found out with the task force that would have to be overcome.
Yeah. Other questions? I'm sort of cruising through the pictures here. Anybody want to raise your hand or speak up? Other questions or comments?
There are some in the chat. I'm not sure that they have been addressed.
Okay.
Well, there are really no other, oh, well, okay, Susan did post another one. Medical transport for health appointments. So, again, from Susan, she was just kind of asking how, I think within the system, do we make sure that medical transport for those who need it is available for any appointments? Correct, Susan? Okay, yep. And I see Bobby's waving her hand too.
Yeah. Yeah, I was just wondering, how do we tie these together and where do we insert it in the total plan? In other words, you've suggested a lot of good ideas. I think everybody has suggested good ideas. But how do we tie them all into the plan? That's supposed to be being developed as soon as a committee is formed to do it. And so how do we take the next step to tie them all together?
I think the governance board is gonna be given and should have that assignment, Bobby. They should pull it all
Understand
together.
that, that's what I just said, but how do we make sure they do it?
Yeah. We attend there, yeah.
Input, your question is, how are we going to be linked into the governance board? Yeah.
Right, how do we are here, all of us, 15 people, I guess, talking about this important issue. And how do we make this information known to the governance board and to the chair of it, or the person who will be identified? Or do we take it to the OMA, or how do we do it to make sure that these things are tied in there?
Well, some of it, in my
I've worked
estimation,
with tribes a lot. I've worked with tribes a lot, and I've been at meetings where all the members of the tribe come to talk about healthcare. And boy, they're all different. They're really, each of them is very different.
some of it, Bobby, I think is doing what we can. And I know HCAO is doing a lot of work on trying to make sure that there are people that could help take that message and are applying for positions on the commission. So I think that's a part of it as well. If we get people on the commission who have an understanding of this stuff going in, then again, as we try and hold them accountable, yeah, I haven't seen anything specific in terms of the commission itself and whether it has any requirements to report on a consistent basis. That's one of the things I've been talking to a lot of people about is transparency. Okay, we got the commission. Do we get, when I say we, the public, get regular reports in terms of what they're doing, what the progress is, what are they working on, all of those kinds of things. I would certainly advocate for that. And again, like I said, when I've had conversations with folks, especially like folks at HCAO, those are the things that I'm bringing up in my conversations with them.
But Bobby, again, I'll go back to when I was on a public service commission, and whenever any of the regulated industries were making changes to their rates or their capital, new buildings, new facilities, there were public hearings that were required, and those public hearings were required to be held in every major city and also every county. And until all of those hearings were conducted, no action could be taken. So on an annual basis, there's going to have to be a feedback mechanism for those types of proceedings, public proceedings, where the public is constantly informed of, here's what this program looks like, and we're trying to improve it. Even things such as global budgets. I know for a fact that the hospitals are going to demand annual meetings to have the global budgets improved, and that's terrific. And all of those hearings should be public, out in the communities where the hospitals sit. And so again, that's what has to be designed and built into this whole program, that feedback.
Thank you.
Mike has a question.
Yeah, any route that we can, I'd say, Bobby. Also, for example, the Oregon Health Policy Board meets once a month. I think it's the first Tuesday, 8:30 to 12:30. And up until now, there's been very little, no discussion of 1089 or the governance board. Fortunately, John Santa is still on the Oregon Health Policy Board, which is sort of an oversight board for the Oregon Health Authority and public health and everything health related in Oregon. But that's a place where they do allow public comment, and we need to just bring it up in their consciousness as often as we can. We have one more ally on that board now, which is Dr. Tony German. He was just admitted to that board. So that's another route. And then House and Senate healthcare hearings. There's probably going to be opportunities to make our point of what we want that governance board to do when various bills come up.
Okay. Other comments? Maybe somebody who hasn't had a chance to have a comment or a question yet.
Bobby.
And Bobby, I just want to, remind you that they're a public body, the governance board, so they will have to, their meetings will have to be open to the public. So, now how much they'll allow for public comment, I don't know. I mean, that remains to be seen, but all their meetings, according to Oregon law, have to be open to the public.
Yeah, I wonder whether we should at some point appoint one of us to look at this component, another one to do this component, so that we are sure that someone is making these points to these public bodies, so that it doesn't just kind of feed into the atmosphere.
Yeah, that's a good point. We may have to reorganize ourselves just a little bit as this gets rolling. And I could even see maybe a meeting between the legislature